I request everybody to please
call
limit
end to
the number of
session.
questions to 3 per session because we are at a tight schedule. Please, esteemed faculties, please come to the center of the stage for the photo. Meanwhile, for the next session, it is a panel discussion on CA colon. I'd like to invite the chairpersons for this session, Dr. S.K. Nigam, Senior Surgeon from Bhopal, and Dr. Ajay K. Nanver, Associate Professor of Gastroenterology from GMC Bhopal. The panelists for this session are Dr. S.P. Mishra from Prayagraj, Dr. Sunil Kumar from Bhopal, Dr. Pavan K. Addala from Hyderabad, Dr. Kamlesh Talesra from Bhopal, and Dr. Atul Samaiya from Bhopal. The moderator of this session will be Dr. Sanjay Kumar.
So, without further delay, our panelist is already on the dais. I request Dr. Sanjay Kumar to please start the panel discussion on the carcinoma colon. Please, sir.
Thank you, Chairpersons. I have a very elite panel to discuss about carcinoma colon, which is perhaps the biggest problem, and if not, it is going to be one of the biggest problem as far as GI cancer is concerned. We have Dr. S.P. Mishra from Prayagraj, a senior gastroenterologist, Dr. Pavan Addala, who is a GI onco and liver transplant surgeon from Yashoda Hospital, Hyderabad. We have Dr. Sunil Kumar, our own medical oncologist from Bhopal, Dr. Atul Samaiya, oncosurgeon from Bhopal, and Dr. Kamlesh Talesra, a senior radiologist from Bhopal. So I'll just briefly introduce the topic. I'll start with history of a couple of cases. This was an 80 years old male who was diagnosed as cirrhosis in 2019 and was admitted to us with hepatic encephalopathy and dyselectrolytemia. So he was being managed as cirrhosis. In 2020 he had bleeding per rectum, and when we did a sigmoidoscopy we found that he had CS sigmoid, biopsy revealed adenocarcinoma. No treatment was undertaken after discussing with the patient because they felt that patient already had a morbid disease and they didn't want to pursue any treatment for cancer. In 2022, he did fairly well for next 2 years. And in 2022, he came with colonic obstruction and we placed a colonic stent for relieving the obstruction, and he again did fairly well. 2024, he has come again with some bowel symptoms, no real obstruction. And we have done a sigmoidoscopy, I'll show you that. He still maintains a good appetite. He has lost 2 to 3 kg weight in last 1 year. This is the sigmoidoscopy which we have done now. You can see the stent. So here is a patient who is a known patient of child C cirrhosis in 2019 and had developed CS sigmoid in 2020, and this is 4 years after the diagnosis of CA sigmoid. He is with us and merely lost 2 to 3 kg weight. Has not been given any treatment, only a stent to relieve his obstruction. This is the picture. There is partial ingrowth in the stent, but we could still cross it and we reach the upper part of the sigmoid. You can appreciate. Case number 2, 62-year-old male came with abdominal pain, colonic stricture at hepatic flexure. Biopsy was inflammatory. On colonoscopy, somebody put him on AKT, but he landed with obstruction to us 10 days later. We did a laparotomy straight away, and unfortunately there was a cecal growth. So this was probably a misdiagnosis, and surgeon performed a right hemicolectomy. Biopsy revealed adenocarcinoma. Went to Mumbai, started on chemo. This was a mucin secreting adenocarcinoma. Unfortunately, he had some complication after chemo and died 3 months later. This is the third case, 60-year-old male, very interesting. 2019, he came just for non-specific symptoms. We did a pan-colonoscopy, found a solitary rectal polyp. Polypectomy was done, showed adenomatous polyp. 2019, 4 months later only, he asked for a repeat sigmoidoscopy. We did it, it was normal. In 19, we had already planned for a repeat colonoscopy after 1 year, but he got it early. In only 10 months' time, he wanted us to do. and unfortunately we found a polypoidal growth in cecum. So mind you, he had a normal pan-colonoscopy 1 year before, but still there was a polypoidal growth now. This was again a mucin secreting adenocarcinoma. So there were no polyps left, still he developed a carcinoma. In 2000, again after 1 month later, he underwent a right hemicolectomy. Biopsy report was T3N1A, KRAS was wild, and MSI was positive. We will discuss this later. And chemo was done, and 2023 we did a colonoscopy, it was normal, and today morning I spoke to him, he's perfectly fine, he's coming for a yearly colonoscopy shortly. So these are the 3 cases we'll base our discussion on. So let's now get on to our panel. What do the experts say about various aspects of CA colon? So I'll start with Dr. Sunil Kumar. What is the prevalence of carcinoma colon in world? Its rank amongst the all cancer, which is a commonly asked question. And is it low in India as compared to West? And why? And if at all it is rising in India, why?
Well, every year almost 1.9 million cases of colorectal cancer are diagnosed world over, and that forms around 10% of all cancer cases taken together. The 5-year prevalence of colorectal cancer in the world is 5.25 million cases. Second question. It is the third most common cancer, and second leading cause of cancer related deaths. When we talk about males, it is third common cancer and third leading cause of cancer related deaths. And in females also, it is the third commonest cancer and third leading cause of cancer related deaths.
So it's fairly common. Incidence is low in India as compared to West.
Low in India, because when we talk about age standardized rates, it is 7 per 1 lakh population for males in India and 5 per 1 lakh population for females in India. And in comparison to Western or countries high on human developmental index, there its incidence is around 40 to 50 per 1 lakh population.
Yeah.
And the possible reasons are that the consumption of processed food and meat is quite low as compared to Western or those countries where its prevalence is high.
But we are moving in that direction. Even processed food is increasing.
That is the reason for increasing in the incidence of these cancers in India.
Perfect.
Besides that,
so that's what Dr. Sunil has told. This is the third most common cause of cancer in men and second most common in female after breast. We'll move forward to Dr. Atul Samaiya. What are the clinical presentations? How does the patient present? What percentage are diagnosed after symptoms and what percentage are asymptomatic when they are diagnosed? You can keep on the slides, please, sir.
Yeah, basically the symptoms depend on the site of disease, whether it's a right-sided colon cancer, left-sided or rectal cancer. Generally, the left-sided colon cancer present with the early symptoms compared to right side. For the right side, we see classically 3A, anemia, asthenia and anorexia. So, and for the left side colon, generally the features of obstruction, pain, increased frequency of motion, tenesmus for the rectal cancer, mucoid stool, bleeding per rectum, melena. These are the common symptoms when they present to OPD. However, if you see the true incidence of asymptomatic cancer is exactly not known, because if you are doing a screening test, it is different. If you see the data, the skin detected cancer accounts for around 10% of the overall colorectal cancers. But if you see the true incidence of asymptomatic patients coming and detecting cancer on colonoscopy done for some other cause, like in the other case, that comes around to 1%.
So in West, where they have an active screening program, they do diagnose 10 to 15% cases on screening only. So don't ignore your symptoms like change in bowel habit, bleeding from anus, blood in stool, abdominal pain, loss of appetite, persistent lethargy, pallor, or unexplained weight loss, which applies to actually most of the cancers. These are the very important symptoms. So I'll just skip this. Dr. Atul has already said it. So again, Atul, what are the risk factors and what is the diet which predisposes to cancer?
If you see, the risk factor applies more or less common for all the cancers and similar for the colorectal cancer. Around 10 to 20% are hereditary. If you see, take a detailed history, only 10 to, in Indian context maybe little less. Then the processed meat, as mentioned by Sunil, processed meat, chronic constipation, then inflammatory disease like ulcerative colitis and the Crohn's disease, almost 10% patient in more than 10 years time they develop the cancers. Then alcohol smoking, which applies to almost all cancer. If somebody is drinking more than 3 packs per day, he has a high risk for colon cancer. Type 2 diabetes has been associated with the cancer, but exact is not known. Similarly, smoking, the person who is quit smoking again still have a high risk for the cancer. And
So low fiber diet, addictions,
low fiber, yes,
perhaps diabetes.
and obesity,
Yeah.
and lack of physical activity, which is common to almost all cancer.
So as he said, there are certain non-modifiable factors like age, family history of colonic cancer, polyp, history of other cancer, genetic conditions, IBD. These you cannot modify. But what you can modify is a diet, cooked meat, unprocessed food, diet low in fruit and vegetables, heavy alcohol, smoking, sedentary lifestyle, obesity. Even obesity is a risk factor for most of the cancers. So proceeding further, Dr. Pavan, what percentage of cancers develop from a polyp? And if not, how do other cancers develop? And what are the various polyposis syndromes?
Percentage of cancers from a polyp depends upon the type of the polyp that we see. If we look at adenomas as a whole, 10 to 15% of them will develop into a malignancy. And if we look at advanced adenomas like high-grade dysplasia, more than 10 mm in size, proximally located and all. So these kind of polyps, they have a higher tendency of developing malignancy, to probably around 45 to 55%. Whereas when it comes to serrated polyps, high-risk serrated polyps particularly, they have around 35% of getting a cancer out of them. Cancers can develop without polyps also. That is because of the rapid hypermutation that happens and hypermethylation that happens at the genetic level, which will cause cancer to directly develop without
certain
following this
genetic
adenoma
mutations which can lead to cancers.
Yes. So it's particularly based on the mutations. Without polyposis, they can directly jump because from tumor. From the start of the tumor to the growth, it happens very rapidly.
As happened in our third case, who did not have a polyp in previous colonoscopy, but developed a cancer almost 10 months later, a big growth.
So that's definitely possible without a polyp. And we have different types of polyposis syndromes based upon the kind of polyp on histopathology. We have adenomatous polyposis syndromes. Typically, it is either HNPCC syndrome or a FAP. Then we have solitary serratus polyposis syndrome. Then so we have hematomatous polyps.
Yeah, we'll come to that
everything.
again. Yeah.
All those things.
Yeah, thanks. So about 75% of colorectal cancer start from polyps, rest occur de novo. About 80% of all colonic polyps are adenomas. About 5% of adenomas are actually malignant when they are diagnosed. So I think we can have an audience question at this time. So any PG can answer this. What are the various types of polyps? Anybody? Anybody who's awake and listening? And which of these are pre-malignant? Any PG would like to take it over?
Sir, in the same context, I just want to Dr. Atul Samaiya that villous polyposis is supposed to be a precancerous condition, and there are two types of treatment advice for that. One is the sleeve resection per rectally, and another is the resection of the particular segment of the colon. Which I want to ask, what is the size of the villous polyposis which should be removed by sleeve resection and which should be by the resection of the colon?
Sir, we have some questions related to resection. We'll come to that. So basically polyps can be adenomatous, hematomatous, inflammatory, etc. But mainly adenomatous polyps carry malignant risk. So coming to Dr. S.P. Mishra, what is the role of screening for diagnosis? Who needs screening? Is it relevant in India?
Well, again, there's a carcinoma sequence that, like you said, that adenomas develop into carcinoma and the polyposis syndrome. So screening is very important for diagnosis of early cancers and prevention of cancers and deaths. In the West and in the most developed countries, and even in China and Japan, I was there in Japan for this training. You know, they have this is way back in 2005. They have a team of 15 people who just do colonoscopy screening, not therapy, only screening. That number probably will get in the near future because more people are coming out. There's a deficient of number, but screening does help. And the screening program is anybody above 50 gets a colonoscopy done. The Cancer Society of American Society of Gastroenterology advises at 40, 45. And if somebody has a first degree relative who develops a cancer before 60 years of age, or two relatives at any age, then you do it at the youngest person developed 10 years before that. 10 years before that.
Yeah.
And then follow them up every 3 to 5 years. Remove all the polyps seen, and if the adenomatous, decrease the seeding period. And fecal occult blood can also be done. That's very good. And Japan mostly uses the fecal occult blood. Who needs screening? I told you, people with familial polyposis, those who have history of family. But in the West, everybody is getting a colonoscopy done. And probably with, like you said, changes in the lifestyle and the diet, the reporting is more, probably we'll need screening. I talked to the ICMR people in 2005. They rejected the proposal because they said it's not possible.
It's going to be relevant in our country too. And
it's going to be relevant. I think it is relevant. And whenever I do a colonoscopy, I try to look for polyps, and if there polyps are there, I remove them on the same go.
So at the moment we are doing screening in select groups, like if there is a family history, if there is a polyposis syndrome, then we are doing, but for a common man we are not yet doing. Perhaps it will come. Dr. Chaubal has a point here.
I just wanted to know, panels, thousands of colonoscopies we have done, all of us. In India, how often have you seen a synchronous or a metachronous polyps develop in these patients? Synchronous or metachronous? The reason is very clear. I think it's my experience. You have a malignancy there, but you do not have so many polyps. So I think in our country, this so-called adenocarcinoma, there's something else working other than adenocarcinoma sequence in this.
Yeah, perfect.
We don't have to have so many of polyps. Had it been there, I think definitely screening program would have been there in India.
Yes, sir.
But in these situations, it's different. Early onset of malignancy is also, in the absence of any family history, that is also quite common in our particular situation. So what do you think, sir?
That's precisely the reason that we have not been able to generate a proper screening program, because we do not know our population, how does it behave.
Sir, what you say is right, and that's what we were discussing. I know of 3 senior gastroenterologists who was diagnosed with adenomas, one with CA in C2, and they're doing very well because they underwent colonoscopy spontaneously because they thought that they should go under screening.
It will have a relevance, but I
Definitely.
think we have to generate some data. So we'll proceed forward. So what do you do for screening? You can do a colonoscopy, which is the best test. But of course, to reach to a colonoscopy, the fecal test is very important. Nowadays, we have simple fecal occult blood testing or fecal immunochemical testing. This is the data from West. So this is how colonic polyposis, adenomatous polyposis looks like. So, Pavan, what is the protocol for screening family members of the CA colon patient in family clustering, in polyposis, in HNPCC, etc.?
The first most important factor is the clinical history.
What is the screening protocol? I mean, see, like sir said, in West it is 50 years for everyone. Now it has been lowered to 45 years.
If family clustering is there, then we have to start at least 10 years earlier.
10 years before you had a patient of polyp or cancer. I think that is what should be the message.
Yeah.
The second thing I would say is that in increased risk population as polyposis, etc., in FAP, like they say that you start screening at 10 to 12 years of age.
Whereas HNPCC we start around 20, and then SSPs we start around 30, 35.
So very important message that if you have a family member who has got a polyp, or adenomatous polyp, or a cancer, then you start at 10 years before index patient. So if somebody had developed colonic polyp, adenomatous or malignancy at 40 years of age, his family member should start screening at 30 years of age. So this is a very important message which I wanted to convey. Yes, Dr. Sahu.
Just a minute. I don't think colon screening is the need of the hour. And
in India?
Yeah, in India. In India. I'm talking Indian context.
That is what Dr. Chaubal has also said already.
Okay. So we move on.
I think so. That's what that has been conveyed well.
But Sanjay, we can have fecal occult blood done. We can have fecal occult blood, and those who are positive can.
I think it will need some discussion. We can have it at the end.
The opportunistic screening can be done, which you have mentioned. Mass screening definitely is not the need of our for India.
I mean, that's a topic for the entire day, that whether we should have a screening program in India or not. So let's go forward. So this was very simple. Again, I think audience is not connecting. I thought, what would you do in a patient with a report of FOBT positive, fecal local blood test positive? Whether do you do a colonoscopy, an upper GI, or both upper GI and colon, or you repeat, and some people even give just anti-amoebics. So anybody from the back? So I think the message here is that there was a beautiful study in the British Journal of Surgery long back, and they actually concluded that most patients finally would have to undergo, if you have repeated the fecal occult blood testing, then finally they would have to undergo both upper and lower studies. Anyway, so how do you do an early diagnosis, Dr. Mishra? And I'll need a comment from Kamlesh also as a radiologist.
Well, you want the role of magnification endoscopy?
Yeah, how do you do early diagnosis? Yeah.
Early diagnosis,
Magnification
basically,
endoscopy.
what you said, sir. Fecal local blood can be done in most of us, and it's not expensive and easily
does
done.
magnification endoscopy help in that?
Okay, definitely, it does help, and NBI endoscopy also help, because it helps in basically not making early diagnosis. Your eyes have to be trained to pick up the.
Yeah.
Now we have something known as AI is coming in, which is going to help you in detection of
Yesterday
early
we
polyps.
had two beautiful lectures on the same topic, one by Dr. Mohan and one by Dr. Prakash from Kochi, and they both emphasize that the quality of our endoscopy and colonoscopy has to go up.
Yes.
And we have to devote sufficient time to each patient.
Sanjay, that can only be achieved if we have more gastroenterologists. We are so pressed for time doing so much procedures.
More gastroenterologists would like to do more endoscopy, still they will give less time.
Because of the
I
population.
don't know whether
agree
the
with
mental attitude has to change. Kamlesh, any role of radiology in picking
Yeah,
up
so
early cancers?
in early diagnostic workup, where we can make you free and imaging can help is CT colonoscopy. So CT colonoscopy is easier procedure to perform. Just need a bowel preparation followed by bowel distension. And the newer equipments coming are integrated with AI. So AI, continuous deep learning, and which is giving, now the images of CT colonoscopy are getting much better. So not just polypoidal lesions. Now these colonoscopies will be able to perform ulcerations as well. And AI will help in localizing the lesions as well as to an extent characterizing the lesions, which can definitely be counter-checked by the radiologist. So, like sir said, the workflow, so yeah, definitely. So CT colonoscopy can help you take out the burden of doing colonoscopies to an extent.
But you are
Till now it
burdened.
is option for the patients where colonoscopy is not possible or patient is not willing for that. So till now that is the option, but over the time we can say the role may grow.
Okay. So we'll proceed further. So if there is a polypoidal growth on colonoscopy obviously knows that this is a malignant growth and he will take a biopsy. But what are the features in a polyp which suggest malignancy, Mishra sir? And do you take a biopsy or do a polypectomy in all patients where you find a polyp?
So the last question first, any polyp I see, I just remove it out.
So polypectomy should be done rather than biopsy. Yes.
Simple answer.
Any features in
Features
the polyp?
for large polyps, irregular polyps, bleeding polyps, friable polyps, and discolored polyps. Polyps that are blackish in nature, they suggest malignancy. And then you can see they are tethered to the colon also. There.
Correct. So adherent polyp with ulceration, firm consistency, friability. So those are the features that we endoscopists should look for and should be aggressively pursuing it further. Dr. Kamlesh, this is a very common sonographic finding, and this has actually given all endoscopists so many colonoscopies. So is a reported thickened sigmoid or ileocecal region on ultrasound. So what do you suggest? Do you do a second imaging or shall we go for a colonoscopy?
Okay, so I may be biased for imaging possibly, so I will ask for Dr. Atul's opinion also. Means I will consider everything in this, just thickening. So thickening may be a variety of causes, right from the neoplastic to inflammatory. So I may go for a comprehensive CT to look for exactly what is the picture. Many part of the bowel which we are not able to see on ultrasound. So many part of the stomach, abdomen, especially in the bowel, we are not able to see on ultrasound. So getting a comprehensive picture on CT and possibly then doing any invasive procedure might be more fruitful.
Yeah, because often it is because of this unprepared colon. The stool is giving that appearance, and often that's the finding we have found. I'll proceed further. So, Atul, what are the various stages of CA colon? Just in brief.
So
1
like,
to 3.
like for all malignancy, it is stage 1 to 4. Generally, it is on the based on TNM. T for the tumor size. So here is the depth. It's not the size. It is the depth. Tumor confined to mucosa, submucosa is T1. Going to muscularis propria is T2. And if it is crossing the muscularis propria up to serosal surface, it becomes T3. If it is invading or adherent to the adjacent structure, crossing the peritoneal basal surface of peritoneum, it becomes a T4. For nodes, any node positivity is N1. If more than 4 nodes are positive, it is N2. So this is basically based on that, it is stage 1 and 2. T1, T2 is stage 1, T3 is stage 2, then the all node positive are stage
T3.
3 and metastatic disease are stage 4.
So, is it easy to classify before surgery these patients into TNM classification based on imaging only?
In few cases, if the nodes are definitely positive, it is adherent to adjacent organ, we can classify them T4 lesion and the node positive.
So one
Even
should
in
try
many
to-
cases, nodes are negative on the final histopathology. So the final histopathology is the final staging in these cases.
So the colectomy specimen gives you the final staging, but on imaging also you are reasonably sure. Kamlesh, what is the best imaging modality for CA colon and rectum?
Yeah, it's very important to discuss because everybody come across this with the question. So yeah, I will rather start from the below, the difference between rectal CA and proximal CA. So yeah, so there we decide rectal CA because we all know MRI has got excellent soft tissue differentiation when we talk. So it is the positive of MR. What is negative is a time taking and relatively the mobile part of the bowel is difficult to image. So when we come to rectum, so rectum is excellent imaging with the MR, so MR definitely is the gold standard. So when rectal malignancy we are talking about MRI. When we come up the proximal bowel, so proximal bowel we can have both the options. Even theoretically MRI is good, but practically CT gives us equally good information doing the CT abdomen. And now I understand in CA colon when we are working up, so CT chest is also required.
So why not do MRI in all? Why do CT at all?
For what, sir?
For CA colon, for rectum MRI is best. For colon also you said MRI is reasonably good, comparable. So why not do
Yes.
MRI only? Why do CT at all?
So when we are working up chest, abdomen, pelvis, so it becomes reasonable, means many a times it is less time taking, and MR time is the one thing. Availability of the equipment and comfort of the surgeons, number 2.
And movement
number 3 is yes, patient. So patient cooperation if not good, then in MR not we are getting consistent quality as good as CT. In CT almost consistently we will get good quality. So if it is non-rectal malignancy, we can opt for directly CT chest, abdomen and pelvis. But for
In
the rectal
rectal
malignancy,
MRI?
definitely abdomen, MRI abdomen and combined with CT chest.
So he's very clear, for rectal do MRI, for rest of the colon do CT, chest, abdomen, pelvis.
There I will just differ. Based on the institute, you can decide on that. Again, their theoretical advantage of MRI. So if you are good at MRI and you have good protocols for MRI, you can go ahead with MRI with combination of CT chest. Both the options are open as per your institutional practice.
So
even for rectum, I would like to have a CT chest and abdomen along with the MRI pelvis for the rectum. So I will not go for the MRI abdomen until there is liver lesion to quantify whether they are multiple, single.
Yeah.
So my choice will be as a surgeon, because I can read the CT scan properly, but I need MRI, I need Kamlesh help for MRI.
That's also an issue, that we can read CT better than MRI ourselves.
But
Pavan
okay,
and Sunil,
so but here definitely the take-home message should not be this, because this is not what is suggested, which is advised. Because see, when we are dealing with CA rectum, so definitely liver lesions we are looking for. So, and doing the one study when we are doing pelvis, we are giving MRI contrast. So it's always better to complete the abdomen in that same sitting. So that's fine if you feel like MRI, you are not happy with the MR upper abdomen part, then later on you go for CT is different thing. But in the same sitting you can
come. I would like to ask one thing. In NCCN, for chest uniformly they have always mentioned CT chest. For chest, MRI is not mentioned anywhere, and I have heard from radiologist also that for chest part, HRCT or CCT?
No, I can answer that also, because in chest the MRI performance is not that good because of the motion artifacts.
Sir,
I think
that's why
they always prefer CT.
No, possibly.
So when we are going to for CT chest, it is by simple logistically, it's easier to get a CT chest and abdomen in the same setting.
I think we can close it here. We are short of time.
Okay.
The message is there.
So yeah, CT chest, yes.
We proceed further to Pavan and Dr. Sunil. Sorry, this was the role of PET. Do you recommend a PET scan, and when do you recommend, both of you?
No, I don't do it routinely, sir. I do it in very special instances where I want to start a new adjuvant for suspected spread
So
of the...
for new adjuvant, if you are considering, you would like to give.
In an
Dr.
operable
Sunil?
metastatic disease,
Well,
yes, we do.
There is just one indication, and that is if a patient has potentially resectable liver-limited disease, and in these patients, PET CT should be done. Otherwise,
So if you are
CT scan
considering
is
a
sufficient.
hepatic resection along with a colonic resection, you do a PET CT first,
Operable
because there may be
metastatic disease.
metastasis elsewhere. That's a good point.
And
When there is a reaction to contrast, we can opt for PET scan without contrast.
Without contrast. So, Dr. S.P. Mishra, sir, any other testing on the tissue for you and for Dr. Sunil? Apart from
by and
routine
large, if you get
histopathology?
histopathology, that's good enough, but sometimes you need IHC and all those tests that has been shown by Dr. Chawla and others. So those tests can be done, but only rarely do you need those tests.
Sunil?
Well, the test that should be done on every patient is for MSI or MMR.
Our third patient had
Microsatellite
MSI
instability by
positive.
IHC or mismatch repair by PCR.
Yeah.
Because that helps in identifying patients who are carrying hereditary disease, because that has implication for the patient as well as for his or her relatives.
So I think
And
this
that
knowledge
also helps in-
should be common to all now.
No,
Yes,
but
yes,
no,
sorry.
we only do in younger people if they have more
Yeah,
MSI.
certain
index.
guidelines
Yes.
are there. Yes, sorry, I interrupted you.
And in patients who are having metastatic disease, mutation testings for KRAS, NRAS, BRAF and HER2/neu should be done, because there are targeted therapies for these mutations, and if patients they do not harbor any of these mutations, then we can go for next generation sequencing to identify rare but potentially targetable gene mutations.
Yeah, we'll come to that also. That has come,
Sanjay.
this is a new knowledge, and I think we'll be discussing. Role of MSI testing, sir has already mentioned that in younger patients and patients with synchronous, metachronous colorectal malignancy, HNPCC, etc., it should be done.
Sanjay,
So, yes, sir.
same question. How far has research on E-nose progressed as far as detection of these malignancies is concerned?
E-nose, any comments? This, sir, you can tell about it.
This is a particular thing which I think they have done for, in experiments they have seen that certain melanomas, etc., can be picked up by dogs by just smelling, because certain volatile acids are elaborated, eliminated in the breath, which can be caught in this thing.
I have a
So
slide
just,
pertaining to that in the end. I'll tell you. Yeah.
So they started with the experiments on the dogs,
I do-
that they detected that this patient has a melanoma because of that particular smell. So same thing probably
So
is applied.
a dog smelling the breath is okay, but smelling the posterior.
No, they are elaborated in your breath. Those volatile acids are elaborated in your breath, which are detected.
It is by breath. So,
So I can elaborate on that. There's we have a triple IT, and some people are doing over there. They're about breath and the flatus. They are working on it, but nothing very concrete.
yeah. So coming to next, can I have the slide? So any role of EUS? We have discussed about MRI and CT. So is there a role of EUS particularly in rectal malignancy, Dr. Mishra and Dr. Kamlesh?
Yeah, you can predict, see the depth of the tumor and whether you can resect it or not by endoscopic methods is okay. And by and large, you can see the involvement of the muscles also.
So you can do a T staging perhaps
staging,
better on
better on
EUS. That's
EUS.
what some people feel. But Kamlesh?
Okay. So, sir, means US, because of very high frequency, excellent differentiation of muscle layers, this there. And now, possibly with the US, there is possible to have even elastography. Possibly over the time, it is possible to have USG contrast, and we will be able to do perfusion as well. But still, the limitation is that field of view. So, just even we are not, even at the early stage, T2, T3, we may get some nodes. So, those nodes are not picked up well on US, that has missed. So, MR, now coming to MR, so MR is now, over the time, it is taking up the role of US also. So, if we do proper T2, high resolution T2 imaging, cross-sectional imaging, perpendicular to the lesion, so we are able to make out the layers of the muscles. So, MRI will be comprehensive study for that.
I agree. Even if you do EUS, you cannot bypass cross-sectional imaging.
EUS, if you do, you need EUS plus MRI, but over the time, possibly MRI will do the purpose of both.
So not many centers are doing EUS for staging of rectal cancers now. So coming to management quickly, I have reduced the time by 10 minutes. I am trying to finish. So what is the management as per disease? Dr. Atul has already said 1, 2, 3, 4. What is the management?
Stage 1, it is surgery itself is curative. There is no role of chemotherapy. For stage 2, it is surgery followed by chemotherapy. If it is microsatellite stable disease, in MSI high, again surgery itself is curative. In rectal cancers, we need to add radiation also. In stage 3, again we divide whether it is upfront resectable or unresectable upfront. Upfront resectable, we go for surgery followed by chemotherapy, and in rectal cancers, it is radiation also. In upfront unresectable disease, we go for neoadjuvant chemo and radiation followed by surgery. There is coming role of neoadjuvant immunotherapy also in MSI high patients. Stage 4, chemo, immunotherapy and targeted therapies.
I think the guidelines are fairly clear about this. So that's what he said. So any role of endoscopic resection in stage 1, Dr. Mishra?
Yes.
In very early disease, I'm not saying stage 1.
So you want yes or no? It's yes. Basically, you can remove mucosal cancers, less invasive, the colon is preserved, the patient goes back, but not all cases should be taken up for endoscopic ESG or EL.
So you have to have a good T staging before you can do this. If it is T1, which is only up to submucosa, you can do ESD. But if it is T2, which you cannot identify very clearly in all patients, even after MRI and EUS, you cannot do it. So I think endoscopic resection only for disease up to submucosa.
And whenever there is doubt, call your surgeons.
Yeah, they will operate anyway. What are the various surgeries as per stage? Atul, very briefly.
Basically, for stage 1 to 3, if they are operable, surgery is the main front for the colon cancer. For rectal cancer, yes, stage 2B onwards, we generally prefer the neoadjuvant chemoradiation followed by surgery. And for upper rectal cancer, they are treated like the colon cancer. They are not treated like rectal cancer. Right. So the surgery preferably by the minimal invasive approach, laparoscopically. If not, then the open surgery, there is no difference in the outcome. But yes, morbidity and the overall patient benefit is there with laparoscopic surgery.
Clear. Yes, please give 2-3 minutes. 2-3 minutes. So any role of neoadjuvant, I think he has already said. Pavan, you want to add something?
Yes, sir. So neoadjuvant therapy main role is in rectal carcinomas particularly, where we have to give both chemo radiation. So T1, T2 node negative disease, as Dr. Atul has said, we don't have to go for neoadjuvant chemotherapy. Straight away we can go for surgery, even in the lower rectum. But when it comes to T3 or any node positivity, we have to go for a neoadjuvant chemoradiation therapy. And our protocol is to give for larger tumors, and when we want to do a sphincter saving surgeries, very close to like intersphincteric surgeries and all, we prefer giving a total neoadjuvant chemotherapy, where we give entire dose of chemotherapy and radiation before surgery, and then we take up for surgery 8 weeks after the surgery. If the tumor is small and we have operable liver metastasis and all, we give a short course radiotherapy with 6 cycles of chemotherapy, and then we go for simultaneous resection. Simultaneous resection is what I choose every time.
Simultaneous resection is preferred.
Whenever it's possible, simultaneous resection.
So this he has already covered. I think 5-year survival as per stage, just figures.
5-year survivals are around 65% when all stages are taken together. For stage
65% for all stages together. So it's a very good 5-year survival.
90% or more in stage 1, 85% for stage 2, and it is 65% in stage 3, 13% for stage 4, but potentially resectable liver limited disease that has 5-year survival of around 40%.
So 40% 5-year survival even in stage 4. This is a very important information, and even with liver metastasis, patients can do well after resection. So this Pavan has already said. So I think early or comorbid condition, do you resort to palliative stenting, or there's 2 roles of stenting. Either you do in an inoperable patient, or you do stenting in operable patients to avoid 2-stage surgeries. I just want to comment on this. What is your experience? have you done, Dr. Mishra, surgery in a patient who is operable? You have put a stent and later on surgeon has operated.
No, I have not put a stent in operable patients, surgeons, but when there's
it's
obstruction.
An obstructed patient, and they will do a
Obstruction patient, we
surgery.
have used stents, and like a patient you did, I would have been very wary of putting in a stent there because they tend to bleed, the cirrhotics.
So we have several patients where we have done a pre-operative stenting just to prepare the patient well, and about 10-15 days later surgeon can operate. What is your experience of
I have done 5 cases, pre-operative stenting for left-sided colon. Right side colon I don't need.
Of course, left side.
Left-sided colon, so I have done 5 cases.
So we also have good experience.
And we have avoided colostomy in all 5.
And data also supports. We can have a comment from Dr. Manu and Dr. Rajesh also. What is your policy at AIG? I mean, you do patients who come in obstruction.
So you rightly said where the patient has acute obstruction and the bleeding is there, and then to relieve and the patient is potentially operable, we offer.
And I tell you, all our patients have done well. Do a pre-operative stenting, they are prepared well, abdomen is soft, then surgeon can plan out surgery. Salim, you have a comment? No? Okay. We'll come to that.
So one comment, sir. I think there is one study which has shown 19% of micrometastasis following a stenting procedure. So they don't routinely recommend.
So
but
they
I don't
say
know
that the micrometastasis increase after stenting?
Yes.
There is one meta-analysis which has shown there is no difference in the outcome of the patient. So this is published somewhere in 2016 or 18.
But then you are avoiding one surgery.
You are avoiding one stage surgery, avoiding second surgery, and second thing, micrometastasis. This is some paper published recently which has shown some increase in micrometastasis, but still it is a debatable issue.
No, but barring obstruction, most surgeons will do a one-stage surgery.
Yes, I agree. I am talking only about obstruction, left-sided.
Sir,
Hari has a comment.
This is regarding stenting in left-sided colon. It's indicated when there is an elderly patient having acute obstruction of couple of days duration, or sometimes the patient comes with an obstruction of 4-5 days duration, and the patient is not immediately fit for surgery and the single stage surgery during the resection also.
I think that point is well taken.
You buy some time, you prepare the patient well, and you avoid the infectious complication, you avoid the stoma formation also. Of course, there's no difference in the survival, but the stoma rate is definitely low.
Agreed, you avoid one surgery.
Yes.
Instead of 2, you will do 1, and elderly patient, it gives you time. So I think I can skip few questions. Coming straight away to molecular targeted based therapies, Dr. Sunil, sorry.
Well, there is definite role of targeted therapies in colorectal cancer. Various trials have shown that they not only improve response rates but also progression-free and overall survival. And the better thing is that they are well tolerated, can be used for prolonged period of time, that is till progression of disease or unacceptable side effects in metastatic setting, as compared to chemotherapy where side effects are quite common and we hardly use them for 6 months or so.
So they're fairly safe.
Cost is still a problem because most of the patients are still not affordable for these therapies. Immunotherapy nowadays costs 10 to 12 lakhs per year. When we come to this anti-EGFR therapy, cetuximab or panitumumab, that costs around 2.5 to 3 lakhs per month. Bevacizumab is the cheapest and can be used without any mutational status, or that costs around 50,000 per cycle.
So there are options, though they are costly, and they are well in vogue now. So last 2 slides, 2 interesting new concepts. One was circulating cell-free DNA in colorectal cancer. This can be used for early detection as well as for detecting the primary or secondary resistance. Secondly, as Dr. Chaubal said, the rotten egg smell is from colon cancer. You may train your dogs in future. And they have actually identified increased production of hydrogen sulfide in intestine is associated with colorectal cancer. And this particular study has suggested that it can pick up colon cancer much before they become clinically apparent or even colonoscopically apparent. So this is just an interesting fact. And if there are any more questions from the audience, we will take up. So briefly, colorectal cancer is a very common disease. In India, still not so common. The incidence is 4 to 5 per 2 to 5 per lakh population. Prevention and early detection is possible. Polyposis versus non-polyposis is well studied, but less in India. But there is a huge role of screening in West, yet to come up in India. There are tremendous advancements in imaging, genetics, histology and treatment. Surgery is the best treatment, either endoscopically or operatively, if feasible. Chemo, especially targeted therapy, has emerged strongly. Dr. Sahu is going to talk about that in later part today. And there is a 5-year survival even in 4th stage. This is the most important fact. And there is a lot to come in diagnosis and treatment. Thank you so much. So we can have 1 or 2 questions from the audience. Salim, you have a point.
Sir, I have a strong objection to the comment that was made that screening for colorectal cancer by colonoscopy should not be done in India. It should not come from an academic forum. Say this statement to a person who comes to you asking for a colon scan, and you send him back telling him that it's not required because you're from India, and he presents to you after 10 years with liver metastasis, with lung metastasis.
I fully agree with you, Salim.
Will you have medical evidence to support you? You will not have.
It is like telling all hepatitis B positive patients that you don't need treatment, you are having a silent disease.
There are only,
it should not be done, but of course this is a very going to be a very violent discussion. I don't want to indulge in that, but I take your point.
Sanjay, I have a problem. I am a proponent of that, but there's a problem to it. Screening such a huge population is not feasible. So feasibility is something, if it becomes a government policy, they have to provide it. So I had a long chat with the ICMRP when I came back from Japan. They said the same thing, and I agree with
feasibility is a different, it's altogether...
For individuals, it's okay.
The feasibility is altogether a different thing.
So let me just close this by showing a raise of hands. Dr. Sahu, after your comment.
After my comment.
After his comment, we'll have a show of hands who wants screening in India to be, thought of, or who doesn't.
Everyone wants screening for every disease. That's a fact. But the thing is it doable? Screening is a different word altogether. So even we are not able to do the cervical cancer screening, which is a much more bigger load than this. So doing a colonoscopy and doing that one-off case is not what screening is all about.
So screening is not just colonoscopy.
You have to reach to
can
masses.
Do other measures.
You want to reach to masses to make a screening effective. And colon cancer, the incidence is still not high enough for the government to invest in a population screening program.
It is 45 per lakh in Hungary and 2 to 4 per lakh in India.
You can do a high-risk population screening, that is okay. But you cannot advocate in academic...
So that's your point of view. So shall we have a show of hands based on whatever we have discussed? Who wants screening to be implemented in India?
You have colonoscopists over here, so they'll all agree.
No, I don't see many hands. Please be free to raise your hands if you want screening to be done. I am a proponent. Not because we do colonoscopy, it can be done by other methods also.
Just point to it, cervical cancer screening, pap smear is in the National Cancer Control Program, but that is even not done, which is the most common cancer for females. It is not done properly in India. So for the lower incidence, opportunistic screening is yes. Otherwise, for mass screening, we don't have resources for the mass screening for colorectal cancer.
Okay, fine. So we'll end with a final comment from the chairperson.
So, point is well taken. As Dr. Samaiya says, that it should not be said on an academic forum that it should not be done. It should be done. In England, Kate Perry was colonoscoped, and that her colonoscopy was telecast on a national television, just to increase the awareness of the screening for colorectal cancer.
But I have a different opinion.
So we can't say it should be ruled out.
But then I have a different opinion. Same thing will go progress. See, screening and surveillance, it is basically government responsibility.
Yes.
Remember this. There the patient, payer will be the government. It's not a person himself. If you introduce this as a part of this, like pap smear and all these things, they are also covered under government. There are insurances which cover this particular thing. And so it has been accepted by Medicare in America. It's because the incidence is so high over there. But so same thing cannot be. In this particular academic forum, of course, academic forums can be different for different countries. So it's not that.
Let us close this with a thing that, with a notion that perhaps it is the job of ICMR to decide, not ours. Thank you very much.